I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series, but I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education. In today's webinar, we will hear from Dr. Medha Suwamber about some key points of interest from the 2025 EULAR Congress, which is the European Alliance of Associations for Rheumatology. But before we get started, I'd like to introduce our guest today. Dr. Medha Suwamber is a rheumatologist with Mount Sinai Hospital in Toronto, Canada. She did her rheumatology fellowship and her vasculitis fellowship at the University of Toronto and medical school at McGill University. Welcome, Dr. Suwamber. We're so happy to have you here with us today.
Thank you, Kathy, for inviting me, and it's a pleasure to talk to you today about some of the updates and some of the few highlights that really caught my attention when I attended the EULAR 2025 this June.
Well, this will be great. Before we have you share your slides, if you have any disclosures you could tell us at this time. I'm sorry, I talked over you.
I have no disclosures.
Okay, great. And anytime you're ready, we would love to learn more from you, and go ahead and share your screen.
No problem.
That looks great.
Excellent. So my interest in vasculitis lies mostly in the world of GCA, giant cell arteritis. So most of the highlights that I will be presenting to you today will be focusing on GCA, but I'm happy to take questions on other types of vasculitis at any point during our discussion and talk today. So one of the reasons I actually attended EULAR this year is that I had the opportunity and privilege of presenting one of my papers, which is measuring response to treatment in GCA. So I am currently part of a huge international task force where we are trying to determine how do we assess response to treatment in GCA. What do I mean by that? Let's assume as a patient you're told to participate in a GCA clinical trial, and we want to compare whether a new drug X, is how it's effective compared to drug Y, which is a known drug. So the question that arises is, how do we measure response? How do we know whether drug X is actually working? What is a positive response? So this is what there's a lot of work around that in trying to determine what is response to treatment in GCA. For example, is resolution of headache being a very important piece in a patient who has GCA, is resolution of headache an important item to measure to determine whether that drug X is working. So as part of this project, there are many phases to that project. So one of the phases is to determine the most important and relevant items for measuring response to treatment in GCA. And I presented that data at EULAR. So to present, do this study, we needed not only physicians, but participation of patients. We needed patients' input to really understand what qualifies as response when you're measuring, when you're looking at a drug and assessing response. So we actually recruited patients from the VPPRN, from the Vasculitis Foundation of Canada, and from Vasculitis UK. And I'm glad to say that we had over 80 patients who participated in this survey. Many of them came from different parts of the world, from UK, US, Canada, Australia, and we had their input into determining response in GCA. At the end of this study, what I found and what we all found together based on looking at survey responses of both patients and physicians is we have these 12 key items that will help us better understand and measure how well patients are responding to treatment in GCA. So we divided these 12 items into these 6 categories, into clinical, laboratory, imaging, looking at physician global, patient global assessment, and looking at damage. So all of these will be incorporated, hopefully, in a response criteria that will eventually be used in the clinical trials. So this is one phase of the project. So we are now moving on to the next one, but I presented this preliminary phase, and I feel it was very comprehensive, looking at all these different items that will help us assess response to treatment in GCA. Before I move on to the next highlight, are there any questions you have, Kathy, based on what I just said?
Well, I actually find this slide fascinating. Like it just kind of it like lays everything out so clearly as a patient for me to look at and see how you are coming up with the keys to measure. I did want to ask what the second one is. Amaurosis.
Oh, amaurosis is a transient loss of vision that you can have.
Oh,
And usually that's highly predictive of vision loss. So if you have a transient vision loss that happens and then you're suspected to have GCA, you really want to get treated right away because there's a higher risk of permanent vision loss. So
I see. So also in the laboratory section, I know what C-reactive protein is and the ESR. Do the doctors do other labs as well if there are other things that they're seeing when they're examining the patient, or are those the basic labs that, or are those the basic ones that everyone does and then there are additional?
as you rightly pointed out, Kathy, these are the basic labs that's easily available to everyone. So we wanted to choose items that would be available not only at a research center, but globally when research is being done. For sure, there are other items that can be looked at, but they're very challenging to obtain in a regular lab. So these are the basic things that any physician who is looking at it or treating a patient with GCA would be ordering. So it's sort of a generalized sort of laboratory for inflammation.
And that does make sense. I'm just looking at this graph. It's so easy to understand as a patient. It makes me feel like I could make sure that I was getting the proper care by a physician if I knew this information. So this is very exciting to see. And now,
And
if you'd like to continue on.
no problem. And I wanted to highlight, we also included the patient global assessment. So we really value the patient's input in understanding response to treatment. So that part is also there. So the patient's voice were well heard of in those 85 participants. So I really thank them for participating in this survey. So moving on to the next highlight. So I just took a picture of two slides from a WIN session. WIN stands for What is New, WIN. So there was a What is New session on large vessel vasculitis by Dr. Sarah Monti. And one of the key things that's coming up in the world of GCA is GCA fast track clinics, where patients who are highly suspicious to have a GCA are referred to as specialists, where they are seen within 24 to 48 hours of onset of their symptoms. And when they are seen, they have a comprehensive assessment from ultrasound to a history, a physical exam, and laboratory tests. And based on that comprehensive exam, then the clinician makes a decision as to whether the patient has GCA or whether further testing needs to be done. And these fast track clinics initially started in Europe, and they are now being seen worldwide. And as shown on one of the slides by Dr. Monti, is the consequences of having this fast track clinic is one of the feared complication of GCA, which is vision loss, has been reduced significantly, and that can be seen again in various countries. And the one that I highlight here and showing with my cursor is one of the latest studies in 2024, where they had over 300 patients in the fast track clinic in UK, and vision loss was only, still it's present, but it was reduced to 11% only in the patients evaluated in the fast track clinic versus 18% in those who are not seen in the fast track clinic. So a step towards trying to prevent damage related to GCA, and a feared complication of GCA is these fast track clinics. And I think that's something patients should be aware of, that we are really trying to hone in and see those patients who are presenting with GCA symptoms very quickly to prevent this very significant complication. And other highlights, but before I move on to the other highlights, any questions about the Fast Track Clinic, Kathy?
Yes, I actually have a couple. I'm excited about this opportunity for patients. A Fast Track Clinic sounds like an amazing new thing that I'm just wondering how difficult, what are the challenges involved in establishing Fast Track clinics like anywhere? It looks like you have some in the United States. I just don't know very much about it because I have MPA, not GCA.
I think the main thing is having. In fact, there's a nice article published by Professor Schmidt, who was the one who introduced ultrasound in GCA, and he really wrote and described how a GCA fast track should be done. And the main thing is, first of all, having the right personnel. For example, having at least 2 or 3 physicians in the clinic to help to be available, because the main thing here is seeing patients within 24 to 48 hours. Availability of the physician to see that patient should be there. Most importantly is modality to get those diagnostic tests done. Some fast track clinic use biopsy, but the key in most fast track clinic is the ultrasound, because that's an easy way to quickly determine whether someone has a GCA or not. So the use of ultrasound has really opened the route to the development of the fast track clinic. So having expertise in using ultrasound to diagnose or help to diagnose GCA is key in establishing a fast track clinic. And having the expertise in doing the ultrasound and interpreting the ultrasound is very key. And that's, I would say, another important aspect, other than having the physician, is having that expertise in looking at different modalities to diagnose a giant cell arteritis, and accessing those different modalities very quickly are the key aspects to that.
I mean, yeah, it all sounds like it's that part of it, that piece of it has been well thought out. As a patient, I wonder how, I guess we have some of these fast track clinics already in the United States. I'm just looking and I see that on your graph. So is it working well within our healthcare system? Is it better in Europe than it is here or Canada?
I think a lot has to do with the dissemination of this educational piece of fast track clinic to primary care providers, or these emergency care providers, or family doctors, because they are the ones who will refer. They are the ones who, first of all, see the patient first, and they're the ones who will refer the patients to the specialist. So for me, when I established this, the GCA Fast Track Clinic in Toronto, it was dissemination of that information to the emergency room close to me, to the family doctors I work with, so they're aware that if a patient they are seeing is suspicious for GCA, they know that there's a pathway where that patient can be assessed very quickly. So the key is getting the physicians who are seeing the patients first line knowledgeable about these types of clinics, the availability of these type of clinic, and really it really stands to coming from family doctors and I would say emergency room physicians. So a lot of education dissemination, I would say, is a key piece to bridge that important gap of patient getting that care very fast. Because if you have the clinic, but there is no knowledge about that clinic, for sure, it will certainly not be effective.
Yeah, I guess that's something we need to work on for the future. Establish the clinics, and then the education has to come. And I suppose also how it is paid for through patient insurance or various health policies in the various countries that are different. I guess that's also a challenge.
Yeah, in Canada, because we have the government that helps us, so
Right.
we're good. But yes, it varies according to different countries for sure.
Okay. All right. Thank you. That was a lot of great information. I'm excited to hear this exists, and I hope it moves forward this in the next year or two. So I also wanted to ask you, does an ophthalmologist or optometrist have a role in these fast track clinics as well? Would that possibly be where some patients would come from? Do we need to educate them as well?
Yes, certainly. The ophthalmologists do play a big role, for sure, depending on the patient presentation. Most of the time, again, it depends on the healthcare system in different countries, how that works. But certainly, in some fast track clinic, the ophthalmologist is part of of the physicians involved in taking care of the patient, especially if they are coming with visual symptoms. That will be the key where they play a key role. Sometimes they're the first person to see the patient and make the diagnosis, and then they refer the patient to us, and we help in that diagnostic process. I work closely with an ophthalmologist, for example, and when I do an ultrasound, if it's negative, that ophthalmologist has an extra interest in doing the biopsy. So they have different, as an ophthalmologist, they have sort of different roles, not only with the eye, but also they could be doing the biopsies, because doing the biopsy, which is becoming less and less, I would say, popular now that we have ultrasound. But when biopsies were being done, various specialties do the biopsy. But in my case, for example, my clinic, the ophthalmologist does help me. But going back to the ophthalmology in the world of vision and vision loss, so for sure they play a key role, especially when patient comes with different visual, I would say, vision symptoms, and you're not sure whether that's related to the optic nerve getting involved from GCA. Having them at hand to assess the patient very quickly is very important and effective, I would say.
Well, thank you for answering that. This fast track clinic just fascinates me, but please go on with your presentation.
No problem. And talking about vision loss, we sort of headed into the right direction here. So another highlight, again, in the world of vasculitis and keeping the theme of GCA is having more and more tools to help us not only diagnose GCA, but understand what's going on in patients with GCA and also for prognostication, because I'm sure patients might have gone through these challenges where after the ultrasound, it is negative and they're trying to figure out, do I have GCA or not? Like, what else can I do to figure out whether or not I have that diagnosis? And when a patient presents with vision loss, other than GCA, sometimes there are so many other reasons you can have vision loss. So how to dissect the cause of vision loss? Because vision loss from GCA and from other causes, management is quite different. So to help in that process of understanding what is driving some of the symptoms in patients. So other than using ultrasound, MRIs are being used. So one of the highlights was using orbital MRI to understand inflammation in some of the visual pathways that can lead to vision loss. So in patients who have vision loss not related to GCA, you have some findings that you see on MRI, whereas in patients who have vision loss related to GCA, you have other specific findings. So having this extra layer of investigation to help you dissect the cause of vision loss is very helpful. So again, these are additional tools that you can add on to help make a diagnosis of GCA and understand what's going on in a patient with GCA. And not only MRIs are being used, but ultrasound. You take the ultrasound probe and not only put it over the vessel to help to diagnose GCA, but you can take the ultrasound probe and put it over the eyelid and look at what's going on in the nerve and in the blood vessel supplying the nerve and understand what eye changes related to GCA is going on. So all these modalities are really increasing our understanding of how vision loss, for example, is happening in GCA. And these MRI and ultrasound, especially ultrasound, sorry, one to the next slide. So they are not only used for the diagnostic aspect, but as I sort of alluded to, for prognostication. So once you do an ultrasound and you say that your patient has GCA, ultrasound is also being used to monitor and understand whether the persistence of findings we see on ultrasound, what does that mean? So there were a few studies that were highlighted where when you see improvement in the thickening of the vessel wall within 3 weeks or up to 6 months, if there is some improvement in that inflammation, that is a good sign. That is a good sign that the chance of the patient relapsing is quite on the lower side. So using ultrasound to guide us in understanding how the patient will do is also another step in enhancing understanding of GCA.
Wow, that also is very interesting. And I've heard a lot about ultrasounds. And in fact, I think I read a little bit about the possibility of AI enhanced or AI driven ultrasounds because the ultrasound is so technical. Am I right on that? Are we going in that direction someday?
There was certainly a few, I would say, presentations that EULAR trying to incorporate AI to help in the diagnostics of GCA, for example, ultrasound. So there's a lot of, I would say, interest in trying to incorporate AI to guide and help in sort of diagnosing and understanding what's going on in patients with GCA. But the challenge is that it's not an easy pathway because, as I alluded to at the beginning, is when doing an ultrasound in GCA, you have to have the right expertise and sort of modulating that AI to really capture that expertise is very important. But certainly, because we don't have many experts in GCA, having AI incorporated to help facilitate and get things going in our patients is certainly something that is being looked at.
Well, I think that that's something that's going to be great for their future. I think some people are scared of AI, but I think, as you said, it's so complicated. Maybe AI can help drive it a little bit better. But thank you so much for explaining that to us.
My next slide is just one slide on treatment. And for patients who have GCA, other than using prednisone, you might know that you also have biologics out there to help to treat GCA. And one of the biologics that has already been FDA approved and approved elsewhere is tocilizumab. But there's another one that has recently been FDA approved is Upadacitinib, which is a pill rather than an injection, which I'm sure patients will be enticed to be taking rather than taking a needle every week. But why I'm presenting this is one important concern that's always expressed is, oh, I'm going to add a new medication other than prednisone to treat my GCA. What's going to happen? Am I going to have more side effects? You just keep on adding medications. So what's going to happen? Like, is my infection risk going up? So this slide beautifully shows that, adding these biologics to the standard of steroids that is usually given in patient really does not increase the risk of infection. So what I'm showing here in the middle slide here is a graph of patients taking upadacitinib for GCA. So the green one is 2 different doses of upadacitinib, and the gray one is placebo, where they only took prednisone. So at week 26, there was no difference in terms of serious infection, as shown in the dotted line. But after week 26, those in the green and blue, the upadacitinib group, they stopped using prednisone, whereas the placebo group, which had prednisone, continued using prednisone. And you can see the graph sort of splits, showing that the infection rate in the placebo group while on prednisone keeps on going up. Whereas once you stop prednisone and continue taking your biologic, you can see that the infection rate is on the lower side, showing how much prednisone, we all want to get off prednisone, but this slide really shows you, like, by adding these medication, it allows us to get off prednisone and therefore reduces the risk of developing infection down the road. So that's a neat slide showing how adding these medications and getting rid of prednisone early on does reduce one important thing, which is the risk of serious infection.
So I was looking at this slide thinking every vasculitis patient wants to reduce steroids. We all know the effects of steroids on us. And I've heard a lot about tocilizumab, but I've never heard of UPA before. So this must be fairly new. Is it just emerging in certain countries? And why would this be? Is it going to be possibly a better alternative for some patients? Is that why it's emerging?
So previously for GCA, as you know, we only had steroids. So since tocilizumab came into the world of GCA, there are many, many trials looking at different biologics to help to treat GCA and withdraw prednisone as soon as possible, if possible. So this drug, Upadacitinib, which is a JAK inhibitor, was studied against placebo and just got published in the New England Journal a few months ago in approximately April, if I'm correct there. And it's the second drug that's now available in again, slowly it's being available everywhere, but for now we know in US it's available, and in Canada it's going to be available. So we are increasing our armamentarium of drugs available to treat the giant cell arteritis. So it's not better or worse. It's sort of I would say, is similar to the tocilizumab. But the difference is that it's a pill compared to tocilizumab, which is an injection. And one of the difference was that the only difference is there was a higher risk of herpes zoster in anyone who takes these types of medications, so they need to get vaccinated. But in general, you want to get your patients vaccinated before starting a biologic. But efficacy-wise, there's not much of a difference between upadacitinib and the tocilizumab. Where we are getting at is like rheumatoid arthritis and other diseases where you have so many drugs available, we are hoping that GCA gets into that direction where we get more and more options available for our patients, especially if they take tocilizumab and have a side effect or they don't respond to it. So we want to have more options for our patients. And this is the second option that's now available for them. But again, it's approved, but I think the reimbursement process is still ongoing.
Right, as it always is in the beginning. But you're so right. It is great to have so many options for patients because every patient is different. So we do hear that all the time. So thank you for explaining this to me. And now moving on.
And I'm going to go on my last slide. I just put it out there because this is such a bench side medicine, as I would call it, really, really at the preliminary phase. So as a patient with MPA, you might know about Avacopan, which is one of the approved drugs in ANCA-associated vasculitis. And the role of Avacopan and the success of Avacopan is really in minimizing the use of steroids in patients with ANCA-associated vasculitis. And we know that steroid is of significant burden in patients who have giant cell arteritis. So researchers in Barcelona actually are studying whether you can use Avacopan in giant cell arteritis. But again, this is really still at a preliminary stage. What they did was that they gave Avacopan to cultures of temporal arteries that had GCA, and it did show that it reduced this inflammatory pathway of inflammatory burden, that you have in GCA. It stopped the inflammatory pathway in giant cell arteritis. So again, it's at the preliminary stage, but we found some positive direction when it was used at the bench side level. So lots of research is being done and trying to use some of the drugs from other types of vasculitis in GCA in the hope of really cutting down on steroids, which is always our ultimate goal.
Wow, I feel like that is really big news. I am an MPA patient, and I do know about Avacopan, Tavneos, the different names that it has, but it's made a big impact on MPA. So I do hope this is a great and upcoming thing for GCA patients. It seems very, very promising. So thank you so much for telling us about that today. I just thought I would ask you, I know that's you, I think you said that's your last slide. I did want to ask you, did you have any just general feelings about things that you heard about that were maybe just for GCA at EULAR, that anything that we haven't talked about so far that you feel might be promising or coming up? Something that we might hear more about next year at EULAR?
From the world of GCA, I think I covered most of the things that's out there, especially in the world of tools in measurement of GCA and diagnosing GCA. I think what I didn't talk about is the small vessel vasculitis. There was a lot of data, especially in the world of eGPA, with the use of the anti-IL-5 receptor antagonists, or anti-IL-5 agonists, such as mepolizumab, benralizumab. Lots of data around that really caught my attention. But it's I can keep on presenting on all the different types of vasculitis, but I think that was another, I would say, key aspect that I've seen. And the other thing that was nice is we had a lot of talks on rarest type of vasculitis, Behçet's. There are a lot of sessions on Behçet's disease and recent EULAR recommendations on the management of Behçet's. So we tend not to see, we tend mostly to see the GC and the ANCAs, but the Behçet's is something we don't hear of. But there was I would say a session on Behçet's on its own, the WIN session, which is what is new in Behçet's. And also there was, as I said, some recommendations in Behçet's syndrome. So that was something that caught my attention, and I did listen to those talks very attentively. And yeah, these are the main things that come to my mind. I think with the Avacopan for ANCA-associated vasculitis, what we'll be seeing coming up next is more of what happens after a year. And I think this is where next year and the year after, what happens after 1 year of using Avacopan? Can you use Avacopan in other subgroups of patients? So I think these are things that were not focused on this year. They just had data on the database for Avacopan, but not the results yet. So I think by next year, we'll get more an understanding of Avacopan, how to use it in ANCA-associated vasculitis beyond 1 year. So we'll get that data also coming up. And yeah, these are some of the thoughts that comes to my mind right now.
And one last question. Can you tell me anything about what EULAR is? Like, it's experts from European countries, it's an association of rheumatology experts, correct? Or maybe
Yeah,
I don't
exactly.
know.
No, you rightly correctly said. So usually it's mostly from the European sort of countries. Like if ACO is more than American, this is the European Association. So most of the people there are from the European countries. We do have people coming from America, from around the world. We've got a large group, quite diverse group of healthcare providers, not only physicians, but researchers, nurse practitioners, so all of them sort of coming together from these various aspects of the world. Especially, it's nice to see from all the other the Asian countries. You see all of those coming together in sort of one place. So it was very nice to see that unity happening.
Wow, that is I was so excited to hear that you were going to talk to us about what happened at EULAR, because I always feel like there's a couple of big congresses like that per year that the major information is conveyed to all the rheumatologists. And I just love to hear that they're working so well together on these topics that are so important to us as patients. So thank you for educating us on this today. We appreciate you taking your time, Dr. Suwamber, and also we appreciate that, of course, the Vasculitis Foundation for their commitment to patient education. And I appreciate as a patient that you made me understand all of this today. So thank you so much.
Thank you for having me. It was a pleasure talking to you today, and I hope I enlightened a few things.